Hello and welcome to ParkOn 2021. Thank you for joining this session where we'll be discussing whether Parkinson's is actually a spectrum of conditions that perhaps have different underlying causes, differing symptoms and progression, which therefore require different treatment approaches. I'll be your host for this session. My name is Rory Cellan-Jones. I'm the technology correspondent of the BBC. I've been doing it an awfully long time, and I'm about to stop in a few days' time. I was diagnosed with Parkinson's at the beginning of 2019, and I've taken a great interest, obviously, in learning a lot about the condition, but also in particular, also in my work, learning what technology might contribute, for instance, whether smartphones can play a part in measuring the condition, because measurement seems to be a huge issue, certainly for me and for lots of people involved with it. So let's meet our two experts for this session. I'm going to get them to introduce themselves. Professor Alberto Espay. Alberto, tell us all about yourself.
Thank you, Rory. I'm just delighted to be here with you and with Michele. I'm a neurologist at the University of Cincinnati. I've been here for now 16 years. I trained in Parkinson's and movement disorders at the University of Toronto, where I also did a master's of clinical epidemiology. And I've been very interested in Parkinson's throughout my professional career, keen on different levels of knowledge about it, and now more so in terms of how is it that there may not be a Parkinson's disease, but in fact many Parkinson's, which I know is the area of this particular conversation. I'm delighted to be with you and Michele.
Great. And Michele, let's hear from you.
Thanks, Rory, for inviting me into Parkinson's UK. So I'm a neurology consultant. I've been a consultant for sort of 17 years now. Before that, I did focused on research PhD in Parkinson's. So I work in Oxford, having trained mainly in London. And I'm quite unusual for a lot of people that go into academic neurology, because I sort of worked in the coalface of being a district general hospital neurologist for about 8 years before transitioning into academic neuroscience, which is what I mainly do. About 50% of my job is looking after patients with Parkinson's and atypical. And I'm also doing a lot of research with a cohort we call Oxford Discovery that has about 1,000 people with their Parkinson's diagnosed within 3 years that we're now following up beyond 10 years, actually, with now further funding so that we can actually track someone's progression from diagnosis to 15 years of living with Parkinson's. And a key aim for this is to be able to develop a set of very basic markers that we can have following a person's diagnosis that will actually give us a rough idea that we can share with them their prognosis, so where they're going to be 3, 5, maybe 10 years after at diagnosis, which is what patients ask me all the time when I have to tell them the news. I'm really interested in using digital technology, low-cost approaches that are going to make a real difference to patients' lives, both to improve their symptomatic treatments, to enable them to proactively manage their own Parkinson's, to get feedback on how they're doing, and to inform clinical trials.
Great. We're going to have a great discussion, I can tell. But before we get started, just a couple of bits of housekeeping for those joining us live. We'd love to hear from you, so please do share your thoughts and comments in the chat. Following this discussion, which is actually being recorded, we will be live to answer questions. So please do raise those using the Ask a Question button, and we'll get through as many as we can. So I think that's everything. Let's get started. First, the big picture, why are we here for this discussion? Let's find out from our two speakers whether they think Parkinson's is a single condition. And Alberto, I'm going to come to you first, because from what I gather, you've been described as a bit of a maverick. You've got a strong view on that, and you're is that right? Not convinced that Parkinson's can be just classified as one single condition?
Well, let me pretend that I'm an oncologist, and I'm going to be discussing my evaluation to a woman. And I'm going to tell her that her left breast has lumpiness to it that the right breast doesn't, that the temperature that I perceive of the left breast is different to that of the right. And I'm going to tell her that I have a device that is kind of an electric brassiere that tells me that the mobility of the bounciness of the left breast is different to that of the right. So I'm going to tell her that based on that evaluation that I've conducted, she has breast cancer. I'm going to tell her that, kind of prove it to her, but that she has to trust me because I am an expert. And I'm going to give her a prescription and say to her, I'll see you in 6 months, see how this works. That would be far-fetched for an oncologist to hear, right? An oncologist never can imagine what kind of disease that person is seeing by virtue of what that person looks like. But that's exactly what we do. We are one of the very few fields in medicine, we and psychiatry, that get away with the idea that we can diagnose a disease by virtue of the way people look. And this is a concept that has been permeating our field for a century. We live according to a nosology called the clinical pathologic nosology, which means that, trust me, you have Parkinson's. I cannot prove it to you. Well, I can show you that you have dopamine deficiency, which I can. But if I wait long enough and examine your brain, I will have been proven because your brain will have these things we call Lewy bodies. That's the clinical pathologic way in which we diagnose Parkinson's disease. And we become an experts at saying, that's how it is. That is the disease that we know. And that we can define it by virtue of what we find at the bedside and the many electronic gizmos that we have to try to measure movements in a more granular fashion. And we have to stop that. I think that this is what's holding us back, is the idea, the belief that we know what Parkinson's is, even if nature has no idea what we mean.
As someone, who was diagnosed nearly 3 years ago, had what I'm told are classic signs of the condition: dragging my right foot, a tremor, stiffness in my hand, was told that was a provisional diagnosis, and then had a DAT scan and was told that was confirmed. Are you saying that I and thousands of others are being misled by the profession?
Not necessarily in a manner that's deliberate. I think we all love a false sense of security because it is a sense of security, even if we don't know what exactly we mean. I think we have been able to live comfortably in a cognitive dissonance. On one level, we can put together a variety of different features into this neat label, Parkinson's disease. On the other, we can tell you and others, but you know what? But you have your own disease. You might, who knows how you're going to progress. You don't ever compare yourself to others. The pathway you're going to be moving is your own pathway. You're blazing your own trail because you have your own Parkinson's disease. And yet when it comes to working on research in Parkinson's, we forget all of that. We act as if we've never meant that Parkinson's is not one disease, but as many, perhaps, as people living with it. That's why I use the example of the breast cancer. The oncologist telling the patient, you have breast cancer, trust me. Sure, you can have a different manifestations of it, but you have breast cancer. We cannot dissociate ourselves from that dichotomy, from that ambivalence. And so we live okay with it. We can accept that Parkinson's is going to vary in different people. And yet we're very close to finding a biomarker of Parkinson's. Mm-hmm. And of course, a treatment for Parkinson's, right? And that's why we have the record we have. That's why we have 0 disease-modifying strategies. We are doing great with symptomatic development for Parkinson's because lumping is okay to develop symptomatic therapies. What's common about Parkinson's? Dopamine deficiency, an eloquent neurotransmitter. So replacing dopamine in a variety of different ways has been very effective. But when it comes to treating the disease, lumping doesn't work. And yet lumping is what we do.
Michele, Let's bring you in. I could see you desperate to come in there.
No, I'm not desperate. I think Alberto makes a really important point. And I think the main reason that we've had to build up what Parkinson's is and define it and make what we call a clinical diagnosis is because we're dealing with the most complex organ there is in the brain. We don't even understand 10% of what the brain function and processes are. And of course, unlike a breast mass or a kidney or a liver mass, it's we can stick a needle in your brain and do a biopsy and hopefully get enough tissue in the area of interest. And by the way, I'd be interested to know from Alberto what would be his area of the brain of interest, because it's a large organ to biopsy to get a definitive tissue diagnosis. So of course, we wouldn't put a patient through brain surgery and invasive biopsy to make a diagnosis at the moment of Parkinson's. So what we have done is, with many, I agree, assumptions, have seen a pattern emerging of a movement disorder, which we can draw a number of increasing level of understanding as to why people develop the symptoms that they have. And we can develop some sort of supportive tests like the DAT scan that you've had. However, I'm often saying to people at the time of diagnosis that my diagnosis is limited. It's a clinically based one. And if I was to compare this with your pathological post-mortem brain diagnosis, which is no good to you now, I would only be at best 85% correct, even if I followed you up quite carefully. So for me...
is that, out of interest, is that the current figure? Is there solid data to say that is?
So there's relatively few studies that have really compared properly the person's diagnosis in life by the clinician with the post-mortem diagnosis. And some of the figures go up to about 93% accuracy. And it very much depends in the kind of scenario in which they were being diagnosed and followed up for their Parkinson's, which is obviously quite variable. But I think if a person can have a relationship with their treating neurologist, and that neurologist has a good level of experience in seeing not just Parkinson's, but also other conditions that mimic Parkinson's, like atypical Parkinson's, drug-induced Parkinsonism, vascular Parkinson's. And that, importantly, that clinician has an open mind and queries their own diagnosis and looks to actually how can we improve the diagnosis pathologically in a way that's relevant for patients. I think that's basically at the first end is doing no harm, and secondly, gaining as much information as we can. So what I'm interested to ask Alberto is, given the limitations in our clinical diagnosis, what is your answer then in terms of kind of better refining the diagnosis, given the difficulty we have with accessing protein pathology, for example, in the brain, the limitations of blood-brain barrier access, what we can access in the spinal fluid, the limitations that we don't even have a dynamic PET imaging ligand, for example, to look at alpha-synuclein, perhaps the most important pathology in Parkinson's. So what would be your solution to this issue?
Well, thanks, Michele. I get that we have a handicap when it comes to tissue-based examination. We just don't do brain biopsies. And the argument is, this is why we're so far behind. It is a handicap, but the major handicap is not that one. The major handicap is cultural. Is the idea that we already know what Parkinson's is, and why would we question it? And the idea that which happened to be confirmed on autopsy material defines a complete disease. So our approach to Parkinson's is forensic, right? So it's saying, we think that individual have Parkinson's disease. Let's wait for autopsy, and voila. On autopsy, we see that there are these things that shouldn't be there. They look abnormal. And we say, well, you know what? That could explain what we saw in life. Not only that, that must have caused the fire.
There must have what?
Must have caused. So we're talking about forensic approach. And what I'm saying is that you see a shiny object in the ashes of the fire and attribute that the source of the fire, that we have found the arsonists. So the Lewy bodies, the Lewy pathology, which is a accumulation of alpha-synuclein in a state that is a cross-beta configuration, is a very, very stable form of the protein, has been considered forever as the cause of Parkinson's.
Well, what I'm not getting here, though, from a patient's point of view, is what you were just saying is there's huge amounts of doubt where it's a much less easily defined condition than we claim it is. What help is that? What course of action does that send you on? I think that's what Michele was asking, and I'm not sure that you're answering that.
So Michele is asking, what would I suggest to do? So the first thing is to completely revert the order of development for biomarkers. So we've argued that part of the problem with lack of successes in disease modification, in neuroprotection for Parkinson's, is that we don't have biomarkers. How have we been developing biomarkers? Well, here's how. We say, all of these people here have something we call Parkinson's. That's the truth. That's going to become the independent variable. And all of these people here have something that we don't have nothing that we can recognize as neurological. We're going to call them controls. Then we're going to test everything we can in spinal fluid, in blood, etc., right? In imaging components, and ask the statistical question: what correlates with this group here that doesn't with this group? And in the process, we call that a biomarker of Parkinson's. But notice that in that order of development, we have elevated ourselves, clinicians, to the role of arbiters of biology. We've said, we know what the truth is. The truth is that which I say is Parkinson's. And these people here have that truth. And now we're asking biology to validate that which we already know to be the truth, which means that what we are essentially going after is common denominators of what happens to be in a population. So if we really are interested in slowing the progression of Parkinson's, we cannot use a cohort of individuals to find commonalities to them and pretend that they are relevant individually, when in fact they are byproducts of who knows how many different things. And that's also why it is hard to reproduce the results of one study from another with another, because there are different cohorts, there are different individuals, there are different biological components to each cohort. So I think that if we were to apply concepts that other fields have done, is that we should be agnostic to the levels, to the labels that we're using for our patients. So rather than starting from the truth, Parkinson's or no Parkinson's, or Parkinson's versus Alzheimer's, for instance, we should start with the idea that we don't really know. We should be agnostic to the labels, and in fact, think about the biological mechanisms of aging. We need to study aging. And why is it that we age in funny ways, some of which we have a name of Parkinson's, some of which we have a name of Alzheimer's, right? So we have different names for these things. And assume that the names were from an era where we have very little else to do, or else to do during lives than autopsies, and start looking at people's living biology. And while it is true that we don't biopsy individuals' brains, we now have something called exosomes, which are thought of as perhaps they're called now the tissue, the blood biopsies of some ways, because they have fragments of brain that we can in fact, or brain material that we can in fact study. So I think that's why I started by saying that the problem with moving forward is not so much the difficulties with pipes in the brain, which I understand we're not going to do, but it's rather the overall conceptual framework of what we're doing to understand Parkinson's in the individuals affected. So I argue we know so much about Parkinson's, the disease we've created, the disease puzzle we've made out to be, and so little about people with Parkinson's.
Michele, we're some way in, and we failed to mention the actual subject that we're ostensibly talking about, which is subtypes. Do you accept that there are subtypes of Parkinson's, and is that a helpful way forward?
So, the first thing is that any person looking after people with Parkinson's will be amazed and struck in a single clinic by the variation between one person and the next that's walking in terms of both the symptoms they've had leading up to their Parkinson's diagnosis and their response to treatment, their subsequent kind of progression. The fact that some people are just their main burden from their Parkinson's is horrific anxiety, for example, which also affects their sleep and causes problems with dreams, nightmares, sleep disruption. And that can be going back for 20 years before the onset of the Parkinson's. And interestingly, it can often still continue and dictate how a person will progress. So any person who is loosely seeing somebody with Parkinson's, however we want to define it, will be aware that there is massive heterogeneity and this is just differences. So and I think also I would agree with Alberto that there are many people I see who I think, you're not that typical person. You've got something else there. If I was sort of, let's say I had a protein probe and I could put that on your brain and I just sort of wanted a readout of what you would call the hotspot, the driver. The first thing is we have to go back to a very long process of 20 years before the onset of motor symptoms. And that is, so it's been gradually accumulating, probably in peripheral body systems like the gut, like the heart. And there is some evidence that it's gradually accumulating there. And then at the time of diagnosis, we see some motor symptoms. I've seen people that I think have got Parkinson's, but they don't respond to treatment. And I've tried really hard with different treatment, and I'm still pretty, thinking have I missed something? Have they got some other atypical? There's got to be a reason. There's got to be an explanation for why this person doesn't fit that. So I think that subtyping is really a way to approach the differences we are all very, very aware of. That are seen in somebody with a diagnosis of Parkinson's. So it's trying to define groups or subtypes of patients that have a set of defining features that could be clinical, tremor, no tremor, the age, young, old, could be biological.
We've already got one subtype that was the only one I've ever heard of, early onset.
Absolutely. Young onset, early onset versus older onset. Absolutely. And that was always one of the kind of ones that was used, in large scale studies to look at genetics, for example. You could also have it as a genetic, you can have a genetic way. So, can we pick a particular gene? Can we then look at whether these people are different from the others that don't have this gene or have a different gene? You could perhaps do it at a pathological level. So you could just reduce it down to what we think is the driving pathology. So it's likely, and I'm sure Alberto will agree, to be a form of protein misfolding, right? Parkinson's, there's got to be an element. So if that's a driving part of it, or whether it's the end result, and the end result is a protective response of the cell to say, I can't deal with all this extra protein, I can't recycle it, I can't get rid of it, so I'm just going to make it into a Lewy body and just parcel it over there. That's sort of, maybe that's a way to improve the cell's function. So that's what subtyping is. It's trying to kind of differentiate different groups of people at different levels. With the aim, and I think it's not a naive one, of expecting that all to neatly fall into place and it's going to give us the answer. But I think just with the humble aim of trying to glean some information recognizing the limitations that, we're sort of, even if we use a data-driven approach where we use the computer to define the groups by just bugging in all the information we've collected, it's a kind of, we're not saying we expect it to be this way. We're just using the computer and we're giving the data input and coming out with things. But that is limited. It's absolutely nowhere near as good as doing individual subtyping. But it's things that we've done over the last decade, and there has been some interesting findings that I think are both relevant for patients to better understand their Parkinson's, but also potentially for clinicians.
Alberto, you strike me. I'm just wondering that you strike me as almost agnostic stroke atheistic about the concept of Parkinson's itself. One would think that would make you just as agnostic about there being different subtypes, or do you see it as a useful approach?
Well, so why are we interested in subtypes? Is it because we're interested in the intellectual idea of how many types of Parkinson's there are? Or are we interested in subtypes because we want to identify the biological driver of an individual's Parkinson's so that we can treat that individual in a manner of the disease, not just the symptoms, of which is all we do, but treating that individual's disease? I would argue that the intellectual pursuit of subtypes makes no sense if all we want to say is there are 15 subtypes of Parkinson's. And so what? What is that? What is the meaning of it? So I don't care how many subtypes there are. As far as I see it, there might be as many subtypes as people living with Parkinson's. My only goal as a clinician is to find a therapy for the people that is in front of me. But the subtypes we're creating are clinical for the most part. They are not biological. They are not individualized. So we've created tremor versus not tremor subtypes, early onset versus late onset, genetic LRRK2 versus GBA. That might be the closest thing to a helpful subtyping, but it's not even that, because LRRK2, which is the most common gene, you would say, LRRK2 PD subtype, that is the most important because it's the most common and so forth. LRRK is a universe of biologies. People with LRRK2 genetic mutation, even the same mutation in the same family, might have different expressions of it. And it might not even include Parkinson's. Most people with LRRK2 actually don't even develop Parkinson's disease. And it is the gene of Parkinson's, right? So you have a variety of different diseases, a variety of different biologies. So knowing a gene, if there is a possibility of understanding what that is in an individual, doesn't tell us the full story at all. It's the beginning of a story that we need to uncover. We really need to the biology. So what we're doing in Cincinnati is precisely filling that gap. There are so many therapies that have been created over decades. At any given time, they were thought to be the cures. Of course, we know that they were applied to populations that were just clinically defined, and nothing ever works. So what we're doing is individual subtyping based on bioassays of those therapies we already have to identify the range in the population of individuals that would be then identified as potential candidates for repurposing therapies we already have. We have great molecules. We just don't know, we have never known who those molecules have been for. That's the only reason to subtype, is not to try to come up with how many types of disease there are. It's trying to identify what is it about the individual that might render him or her suitable to a therapy that we may already have.
And in that process, I mean, is that what you are doing at the moment? In that process, are you basically saying it's not worth me assigning patient A to any particular subcategory? It's a completely specialized approach to every individual. Can you not learn? Can you not define broader categories and therefore learn useful things that would apply to a number of patients?
It depends on what the anchor for division into categories is. If it's going to be clinically based, it is as similar as saying it back into our original example of the oncologist and saying, well, let's define people who have 3 nodules in the left breast and compare them to people who have 7 nodules in the right, and then people who have some nodules in both breasts. And imagine that there will eventually, if we can divide them in that way, that somehow we will figure out what the underlying biology is. That's our wishful thinking. We think that if we organize the way people look, that somehow will predict what the underlying biology for them will be. And that is never happening.
So we took these 1,000 patients, we've longitudinally assessed them clinically with a number of measures, including digital and also blood-based biomarkers, including exosomes, actually. And we used a data-driven approach where they put all of these clinical features, cognitive, motor, non-motor, into a model, and we derived 4 patient clusters. We then looked to see, firstly, is this a one-off? Because many, many studies only show one thing in their cohort and nobody can replicate it, right? So the next thing we did was we looked at a totally separate UK cohort called Tracking, 2,000 early PDs, also funded by Parkinson's UK, very, very similar patient group, unselected, within 3 years of diagnosis, longitudinally phenotyped every 18 months, the same pretty much 90% shared protocol. And we ran the same data-driven approach in all the data in the second cohort, and we found that we replicated it compared to the first. What we then found was that when you combined the data and you found these 4 clusters and you derived them across the 3,000 people now, we found that the progression from each baseline cluster over the next 18 months, just in very simple motor progression measures like UPDRS, which involves tapping, movement, walking, the difference between the fastest and the slowest progressive clusters was 3 motor points of UPDRS per year. Now, why is this important? Because this is a clinically relevant endpoint in many trials that are currently being used, where they're asking for a difference in 3 motor points per year to be evident in the person with Parkinson's given the active drug versus placebo. My point from this study was, if you do not account for this patient heterogeneity that exists in how you select your patients, you will have a false positive or a false negative result in your trial based on errors in how you're selecting and bias in how you're selecting patients. So then we looked for evidence of biological validity in the clusters. So in the most effective severely cluster, we took all the serum at baseline and we ran it in all 1,000 patients. And what we found was a statistically significant pro-inflammatory profile in the worst baseline cluster.
For those of us who are not specialists.
Yeah, so basic bloods that you can do in any hospital with a C-reactive protein and an apolipoprotein A1. And what we found in the worst cluster was that they had a higher C-reactive protein indicating inflammation, and it was higher significantly compared to the other clusters. And they had a reduced apolipoprotein A1, which is a protective anti-inflammatory protein. So we know that the worst cluster seem to have more inflammation driving they have more inflammation than the other groups, right?
Alberto, if we look around the world at the research that's been carried on, is this at a very early stage defining subtypes? Or is this something that, if there is a kind of neurologist stroke Parkinson's global community, is it something that is advancing fast and has become a big area of interest?
It is advancing. I think that people recognize that this would be one way to deal with the heterogeneity. But the problem is that a lot of the baselines on which to create subtypes is clinical. And that's why Michele's approach is one where dividing people into very fast progressors, slowest progressors, is one that makes a lot of sense. At least that's how we view people progressing. And typically there is a lot of predictability. People tend to progress according to how they have been. So we can tell what slope of decline there might be based on what slope of decline there has been. However, the issue here is that whenever we find, so if we can accept that the Parkinson's really isn't a disease, and I think that that is no longer a area of debate. I think all of us accept that this is not a disease. So how are we going to slice it? And here's where I think that the slicing has to be very fine and very biological. And let me give you the only example of a slicing in clinical trials that has had any promise. Low urate is considered a risk factor for Parkinson's. If anyone has low urate, the risk is really high of developing Parkinson's.
And low what, sorry?
Low uric acid.
Right.
Uric acid is a free radical scavenger, is an anti-aging molecule. We all make uric acid. We all make it. It's a very important molecule, and it is known to be associated with Parkinson's when low levels, and then people who have high urate, the people who have gout, for instance, have a very low risk of neurodegenerative diseases. So it's well known that urate probably is something that
gout is a good thing.
So high is a good thing, even if you get gout. Exactly, because gout, and in fact, for the few patients that develop Parkinson's that have gout, they have a really wonderful disease. This is wonderful disease is, of course, not something that we think of it, but wonderful in a benign fashion. So, and then once people have disease, it's been well demonstrated that there is an inverse relationship between the levels of urate and the progression. Those who have low urate levels progress fast. Those who have high urate levels progress slowly. It only makes sense to say, how about if we elevate the urate in people who have low urate and bring the levels to those that we know are associated with the slow progression, right? So far, so good. Well, that study has been conducted. It was finished not too long ago. The publication came out recently. It's the first study that had ever used a molecular marker for recruitment, so that they would have excluded 6 out of 10 patients to get the 40% that actually among the universe of Parkinson's have low urate. And they were given inosine or placebo. Inosine is a molecule that elevates the urate. So the study demonstrated that we can safely elevate the urate with very few cases of gout and kidney stones, which is the other reason gout or high urate can induce problems. What happened to people? Nothing whatsoever. So there was zero change. And I've been part of the committee of looking at the post-hoc analysis to say, well, I'm surely there are some that might have had something to do, right, that could have benefited. And there is not a shred of a signal of efficacy whatsoever. So the moral of the story is that that whenever we see something that seems very exciting, like, for instance, I'm worried about these inflammatory markers that we now think Parkinson's is an inflammatory condition, that we're going to go into a realm of another set of trials trying to apply anti-inflammatory drugs, and we're going to get nothing out of it. So this subtyping business is very fraught with a variety of different problems, and I think that ultimately the last frontier of subtyping is the individual.
God, Alberto, you are depressing me so much here. Yeah, I mean, I want to bring it. We're nearing the close, and I want to bring it back to the patients. And the message that I'm getting from you is, we know nothing, we don't understand it. It's incredibly mysterious, and even when we try and drill down into individual subtypes, we don't get anywhere.
Well, so I don't think we should be pessimistic, but we have to start pinning our hopes on scientific realities. We cannot. So still, the Michael J. Fox Foundation is saying, "Give us your money, and we slow down. We're going to cure Parkinson's." Right? The Cure Parkinson's slogan has to end. We have to end it. It is a false message. Parkinson's will never be cured, but individuals with specific Parkinson's, if we identify them who they are, we can cure them. And that's what other fields of medicine have shown. We haven't cured cancer, but look at the progress that has been done in oncology. So we have to remove ourselves from the idea that because the brain is such a different organ, that it doesn't obey any of the laws of biology and biophysics than other organs do. I think that we have gotten away with too much over the years. So I love keeping the hope, but keeping the hope only so that we don't have to worry about changing what we do is going to get us nowhere. So what is the role of the patients and the advocacy groups is to get us neurologists out of our comfort. We don't like change. We're the most traditionalist of medical species. We love what we're doing. We think we're very close to it. We're just about there. We're about to get a biomarker. It's not happening. We are not going to change unless we have pressure from you, Rory, and from people like you that tell us, you guys need to change. It is not tenable. But other fields of medicine have done this, have accepted negative trials as an indictment of the hypothesis. We never do. Never do. Clinical trials are negative because there is a problem with the trials. The measurements are not good enough. The endpoints, the ways we collect the data is not good enough. The design is not good enough. The patient population is too advanced. That's our favorite. The people are too far gone. We need to treat them when they don't have any symptoms yet, but they are about to develop them.
Yeah.
We only get away with that because we're allowed to, because we think we're very smart and because we think the brain is very special and it obeys really completely different set of rules, although we already have it all figured out.
Michele, are you doing what Alberto says all of your colleagues are doing, being burying your heads in the sand?
No, I don't think so. I mean, I think we're aware of the limitations of the clinical diagnosis. I mean, I tell people about this every day when I make a diagnosis. I explain the limitations, and I think that we're looking at other ways to try and improve Parkinson's. So, you talk about aging. One option could be to look at large populations, large studies or cohorts of people as they age normally, like UK Biobank, like others. And then you could potentially look at how movement may gradually change over that population over time and then you can look back to see what is the earliest kind of either clinical or biological thing that changes in the people that then developed Parkinson's 10 or 20 years ago. I think at the end of the day, though, if to try and sort of reduce it to a purely biological disease, I think we're just quite limited in our technology at the moment in terms of what we can actually meaningfully get from samples that we can safely collect from patients. That's my concern. So, we've looked at whether or not you might be able to individually get a measure of each person's cell function in skin. But however, and then you can maybe develop a kind of therapy-based approach based on skin cells and how those skin cells are functioning and on maybe potential deficits that you might have. And then you can basically extrapolate. Can you extrapolate from skin to brain? How are we going to do this, Alberto? We can generate stem cells from a patient by taking a skin biopsy. We can then culture those cells and make them into brain neurons. And then we might be able to stress those brain neurons by starving them of nutrients or oxygen. But of course, what we're not really replicating is that cells are never in isolation in the brain. They're supported by multiple other cell types. They're in an anatomical defined structure. They have a good blood supply. They have nutrients. And they've been present in an individual gradually aging over 70 years. Now, how do you replicate that? How do you? So I think I'm very open to looking at other options to improve the way we phenotype. But at the moment, I'm sort of struggling to see how this is really going to translate for patient benefit in the next 10 or 15 years.
Well, I'm going to bring it to a close by asking each of you to give a short message to patients about what they should feel about this and whether they should be hopeful or not about the whole idea of delving deeper into the various subtypes, if there are subtypes of Parkinson's. So Alberto, your basic message seems to be we should all stage a patient's revolt and say, you guys know nothing.
So the power that patients have is in actually finally saying, you know what, we're not going to participate in any of these trials because it is not clear what about me as an individual with Parkinson's makes me a candidate for that therapy that you think is going to slow my disease progression. So there is a lot of power in that, but we need to exert it because, as I told you, we neurologists are not going to change from within. We're going to need the pressure from beyond our borders.
Michele, what's your final?
I think I just want to remember the work that's been done on the clinical phenotyping of Parkinson's and what actually that achieved. What that achieved was the recognition of it as a syndrome from James Parkinson onwards. Then somebody looking at the brains of people with this syndrome and discovering that there's not enough dopamine there. And then having the bright idea of giving someone levodopa. That remains the gold standard and best symptomatic treatment that we have for Parkinson's motor symptoms, levodopa. And since the late 1960s, we have not improved on that for symptomatic benefit. We have improved on non-motor symptoms, recognition, treatment, and the effect that they have on individuals. So that's my first thing. Don't forget what we've accomplished before. Don't dismiss it either, because ultimately it was the neuropathological examination of clinically phenotyped patients that led to the best treatment we have ever had for symptomatic therapies, motor for Parkinson's. Secondly, to move on beyond subtyping or clusters, as I've described, we need technology to help us because we need granular level information that an individual can collect over high frequency at home in different scenarios over time. And that needs to be married up with higher frequency biological measures that we can assay in a lab. And I think that the only way we're going to achieve that is through using digital technology to measure Parkinson's symptoms. And by marrying that to more frequent biological estimates, so we start to get a handle on why some people are progressing faster, why some people are progressing slower, why some people get older and older and never get Parkinson's, even though, they have maybe a genetic predisposition or an environmental predisposition. There's something about those individuals that's very different from others, and we don't look at those enough. But I think we need a combination of a pragmatic approach with, technological support like digital monitoring, plus marrying that into sort of frequent biological assays. And I think that the cost and, the availability of the biological assays will improve over time. And I think that will probably lead to better developments in future for people with Parkinson's.
Well, thank you, both of you. That brings this pre-recorded part of today's session to a close. I hope everyone watching enjoyed this discussion as much as I did. A very provocative discussion, I think. Many thanks to our two experts, Michele and Alberto, for their fascinating contributions. And may I wish you both all the best with your ongoing research efforts. Michele, I think you're going to be available for the live Q&A session, which will follow us directly. So to those joining us live, please do stay on for that if you can.
Hello everyone, and welcome to this live Q&A following the session. I'm delighted to say we have Michele and Alberto here with us. Alberto, it's very early where you are, so thank you especially for getting up so early. Unfortunately, Rory can't be here, so I'll be chairing. And thank you to everyone who submitted a question. We've got some brilliant ones, so I think we should get straight into them and get through as many as we can. So the first one is from Neil, and he says, we heard yesterday about the transfer of molecules from the gut to the brain. Is it possible that markers could go the other way, and I guess maybe be used to help us understand the biology, Alberto, of Parkinson's and other conditions? Any thoughts on that from you first?
Well, it's a good question. And actually, it's one that I don't know if we can answer definitively. In theory, yes. My only caveat to the question would then be expanded into biomarker of Parkinson's or bioassay of Parkinson's of whom, right? Of what type? I think that we need to start adding that part onto biomarkers of Parkinson's. I think anything that ends at Parkinson's, it's hard to apply to individuals affected. And so that would be my caveat. We have known so many markers over the years, and we don't know who we might be able to apply those to.
Great, thank you. Our second question is from Rachel, and she asks, are factors like age, sex, or ethnicity related to any particular types or, I guess, manifestations of Parkinson's? Michele, I think.
Yeah, that's a really interesting question. So thinking first about the gender aspect, we looked at this with our cohort and there is a definite difference, and it's really interesting about the effect of female hormones. So if a lady has a oophorectomy, say because she has cancer and treatment, she will become more masculine in her hormones, and then that will give her an inherited higher risk of developing Parkinson's, similar to a man, in that Parkinson's has a male to female ratio of roughly 2:1. So that risk can actually be manipulated or changed by hormonal changes that individuals undergo. So what we did in our baseline paper is we looked at gender differences in the motor phenotype, and we found a broad split. So men tend to have a more upper body, asymmetric Parkinson's with appendicular symptoms like tremor, bradykinesia, rigidity. And remember, this is early on. So this is within 3 years of diagnosis. Their balance and their postural reflexes when you're pulled backwards, which is a type of test we do to assess severity, is preserved. Women, however, tend to have a more lower body Parkinson's early on, and they're more prone to having impaired balance or tendency to stagger compared to men at baseline presentation. So that was the first thing. The second thing is that we do find in general that age increases both your risk of having Parkinson's, but also your chances of having a more severe form when you are diagnosed, and also with progressing more rapidly. So if you're older and you have a higher baseline motor problem or memory problem, you are more likely to progress quicker. The ethnicity question is fascinating, and I would say we really haven't got enough comparator data, particularly in countries like Africa, the Caribbean, Asia. But there have been some population ascertained cohorts that suggest that the prevalence is pretty similar when you adjust for different age survival and age distribution, and the phenotype broadly seems to be similar, but I really don't think we've had any level enough to, of careful phenotyping over time to know about major ethnicity differences.
Wow, thank you very much. Really interesting. And there's another question here for you, Michele, from Andy. Could we retrospectively apply Michele's subtyping to previous clinical trials to reinterpret the results?
Yes. So that's a great question, and it's definitely something that we want to do. So the first thing to say is we've actually replicated our findings with the PD subtype in a totally separate cohort called PPMI, which is the Michael J. Fox funded. And that was done in collaboration with Parkinson's UK and actually with an AI company called Greenhouse Intelligence. And they found very, very similar, the 4 subtypes to what we had done. In terms of some of the drug studies, it is very much dependent on the information that's collected. So some historical drug studies, for example, DataTop, which was sort of a really lovely longitudinal study, focused mainly on motor symptoms, didn't really assess non-motor symptoms like formal smell, blood pressure drop, bladder. They did have limited cognitive assessment. So from that perspective, we wouldn't be able to replicate it in DataTop, But I do think we could replicate it in some of the more recent studies where they've collected broadly equivalent sort of information. And what it comes down to is the data you put into the model. So we're working on what's the minimal data set that you need across a cohort to be able to and it doesn't have to be the same scale, doesn't have to be the same test, but broadly speaking, what can we replicate this using a minimal data set? And I think we will be able to.
Great. Very exciting. And now we've got a question, which I think it would be great to hear both of your thoughts on, which is, do consultants seeing people with Parkinson's already informally subtype people and tailor treatment accordingly? So when someone, depending on their symptoms, does that affect what you treat them with? Alberto, you first.
Well, this issue of subtyping is an interesting one. I think in principle, it makes only sense to be trying to split into what we think seems sensical. The two broad categories of subtyping that we've done over the years have been the tremor versus non-tremor, and the early onset versus late onset, and perhaps more recently, the mild, moderate, and severe kinds of Parkinson's. And I understand that there is a good rationale for them, particularly the latter, which is considered data-driven, is one that is very good at predicting roughly how individuals might progress over time. Now, the question for, at least that I find most important about subtyping, is what is the relationship between that which we subtype and the underlying biology? And that isn't something that we can, in fact, answer to. So far, the relationship between the subtypes and pathology, which is how we defined it in the old model, right? The pathology is that which accumulates in the brain and we think is very relevant. It hasn't panned out. It hasn't demonstrated, none of the studies have demonstrated that there is a correlation between the manner in which we subtype individuals, whatever pathology there may be, either in terms of the amount of it or the distribution of it, much less in terms of the biology. So I'd like for us to start thinking in future subtyping efforts that are more applicable to the individual, where, as you can imagine, it's the ultimate subtyping frontier. We have been able to make sense of a lot of data sets in terms of splitting them into specific groups. But then when it comes the time of trying to understand an individual in front of us, in front of in my clinic, I find hard to exactly understand how that knowledge of information can apply to. So that's sort of where we hope we could eventually go into for all of our subtyping efforts.
Great. And Michele, do you want to add any comments to that?
I think I'm always subconsciously doing that way. So, when I'm first seeing somebody, I'm mentally reviewing things like their age, the kind of social support they have, whether or not they've got anxiety or depression, or importantly, REM sleep behaviour disorder, clinically predating their Parkinson's onset, because that's a really important prognostic indicator. And then also in the examination, if I see somebody whose gait is already affected on a pull test, that's going to influence me. And if the degree of motor severity or cognitive severity at baseline is quite pronounced, that's actually going to, I'm already thinking a bit about, I'm not going to be putting this person for a dopamine agonist, for example. I'm going to be going straight for a medication that they will tolerate the best and will have the least cognitive type side effects. So that's guiding my management, actually, I would say, from the beginning. I think the other thing is, for many people, they, particularly early on in their Parkinson's, it's not the motor symptoms that are the biggest driver of their quality of life. So we showed within Discovery that actually it's the non-motor symptoms that are the biggest driver, like poor sleep, apathy, depression, anxiety, pain, the tremor, the bradykinesia, the movement problem is usually well managed, certainly within the first 3 to 5 years with levodopa. So it's really important thinking a bit about the 4 subtypes we've found is kind of explaining to people that there are these groups, and we do see a link between quite bad anxiety and sleep deprivation, and that also having an effect on their motor symptoms. And just sort of for an individual to understand that if they're really anxious, their tremor or their freezing will get a lot worse, often is quite instructive in then also persuading them that they need their anxiety to be helped to also improve their motor symptoms. So, that is more about integrating the whole person. And, when you're coming to look after them, I've had to become a neuropsychiatrist in many ways because that is part of the whole management of Parkinson's.
Great. I'm sure lots of people listening are thinking, I hope that's what my consultant's doing. Okay, so, and next question is from Graham. I've always had the thought in the back of my mind that maybe Parkinson's is just an unusual part of the aging process. How can we tease apart what are the environmental and what are the biological causes or drivers of Parkinson's? Alberto, can I come to you with this one?
Yeah, that is a very important question. And I don't think we can come up with answers, but I don't think we are able to generate answers that would satisfy individuals. I'm often going, as you can tell, the theme of my responses are related to how much we know about Parkinson's, the disease, and how little we know about the people affected. And so and by the way, all of this sort of dilemma that I have is relevant to what we want to do next in our therapeutic development, not just treat the symptoms, which I think we're doing reasonably well. And Michele has highlighted some areas in which there are opportunities to fine-tune how we can treat patients' symptoms better. But these questions are important to treat the disease. And that's really where our discussion has to change, because the disease is not going to be understood in everyone based on large populations, based on understanding the environmental exposures of a large group of people might not tell us what, at an individual level, those influences may be. 100 people exposed to paraquat, not all of them will develop Parkinson's, right? Some of them will, many of them no, perhaps most of them won't. What is it about those that do? There might be a gene-environment interaction that would imply, for them, that's very relevant, that kind of exposure. So that the answer to that question will require really getting to understand the individuals affected. In the future, maybe part of our discussion will require that we understand the genomic profile of the individuals we are counseling about these kinds of very, very important questions.
Thank you. Yeah, and that's really interesting about the genomics. I mean, is it very common in both of your practices? How common is it for people to get genetic testing? I'm just adding my own question here. Sorry to everyone.
Yeah, it's certainly not done universally at all. And the advantage of having a cohort means that we can test everybody and get their consent to feed back relevant results. For example, if you turn out to have a GBA mutation, that will have an influence really on your whole family potentially, who may also want to be tested. It will have an influence on how old you are at the time of your diagnosis and what your Parkinson's will be like and how it will progress. And it will also make you eligible for a number of trials that are focusing on people who have Parkinson's among GBA carriers. So for me, it was ethically not right to be in a position where we know this information, but we can't feed it back to participants because it's actually going to improve their care, their clinical management. So, we've used the cohort as a way actually to select people for genetically chosen or engineered trials. I think that's absolutely key. In terms of clinical practice, my research experience has then made me much more likely to offer it to people that I see who are not in the cohort, but for whom there is a strong family history, or there's something a bit different about their Parkinson's, or many people would want to get tested, and it can be done on the NHS. And there's a number of pretty comprehensive Parkinson's gene panels now, and I think really the best person to discuss that is the Parkinson's specialist with the individual and counsel them.
Great. Alberto, how about you? How common is it in your practice?
It is now becoming more common only because we're tying our clinical care to our research in patients. Patients are invited to be part of our CCBP, or Cincinnati Cohort Biomarker Program. And through that, then, at least initially, the first layer of genetic understanding is a whole exome sequencing. It will migrate into whole genome sequencing. Now, what we aren't yet doing, I think something that Michele mentioned, which I like, is we're not yet back translating that into the patient. So we're collecting that data, and we're hoping that it will be data that we can make sense of, and that will feed back to the patient. Really, that will be so important. So we've begun the process, but we're not yet connecting the whole thing in the manner that we would want to.
Great. Well, I think we've probably got to stop there because we have run over a little bit because we had so many brilliant questions. But thank you so much both for joining us and giving your brilliant answers to the questions. And thanks everyone for submitting your questions, which were absolutely brilliant. We're going to take a break now for a few minutes, and then we'll be back at 11:30 for our next session, which is all about the future of clinical trials. So don't miss that. We'll be back at 11:30. Thanks everyone, and bye for now.